Thank you very much, and thanks again for the great honor of being able to address this Congress and seeing many of my old friends here in wonderful Brazil. I'm going to talk about total hip arthroplasty for acetabular fractures, and really this starts in my career early. It was my first great passion in orthopedics was acetabular fractures. And I had the opportunity many years ago when I was much younger to be at the beginning of my career with Liternel, very excited to share his passion for acetabular fractures. So it was always my great love to fix acetabular fractures. But it was always a little hard for me because even in the hands of the great masters of acetabular surgery, the results are not as good as we would like. In the hands of the greatest masters, we still only have 75% good or excellent results. And as we've seen from Michael and Kyle, we have the big problem and the growing problem of osteoporosis and our aging population. So we have 75% good or excellent results in young people with motorcycle accidents and things like that. The results get even poorer when we start to talk about people with osteoporosis and especially impaction of the articular surface and other poor prognostic signs. So through my career over time, because I always did both acetabular fracture surgery, trauma surgery, and total joint replacement, I started to think, well, maybe it isn't a good idea to fix all these cases that look good originally but quickly go on to a bad result and we end up with a total hip arthroplasty. Maybe it made sense to begin with the total hip arthroplasty in this older patient population. Because if we say in acetabular fractures we have 25% poor results, fair or poor results, that's really hard to justify in the modern age of total hip replacement, where the results are 95% good or excellent in a very short period of time. Of course, doing a total hip in a patient with an acetabular fracture is different than doing a total hip in a patient with a primary total hip, but still there are questions. So through my career, I started to do some acute total hip for acetabular fractures and increasing over time because the theory was I would avoid prolonged immobility in these patients. The fracture surgery is much easier after you've resected the femoral head. Total hip arthroplasty is easier when it's fresh tissues rather than scar. And maybe we could avoid secondary surgery and complications and have a better result, although we don't know. So over the 10 years at Harvard, myself and my partners, Malcolm Smith and Mike Weaver and David Lowe, there were selected cases where we were doing total hip arthroplasty acutely for the acetabular fractures. More me, Malcolm Smith, a real trauma surgeon, he still believed that we should fix all the acetabulums. I was believing more we should put in some total hips. So that set up a nice study for us. We had 70 patients to look at. Back on, 33 of the patients had open reduction and internal fixation, and 37 had primary total hip arthroplasty. Mostly my patients had the total hips, and Dr. Smith's patients had the ORIF. For me, the indications for a total hip was if it was unlikely to be able to achieve a good reduction or maintain a good reduction, then I was likely to steer towards acute total hip in these older patients. And if they had good bone, if the bone was solid, good pieces, I would still fix them. But we broke down into not a true randomized study, but at least two groups we could look at. So when we looked at these patients and followed up, there was a much higher rate of reoperation on the patients that had open reduction in internal fixation. 30% in the patients that had RIF. Most of those were converted to a total hip, but we also had infections, 4 infections, and some heterotopic bone. 14% that had the acute total hip arthroplasty, 3 for infection and 2 for instability. None because there was loosening of the components. Now this wasn't significant statistically, but we really didn't have the power. We think that, if we had more patients, I'm pretty sure we would have shown a difference. One surprise in both groups in these older patients is the high incidence of heterotopic bone. So 11% and 9% of these patients had significant Brooker 3 or Brooker 4 heterotopic bone. And after we started looking at these patients, even though they weren't extensive exposures, we started to radiate these patients, whether we were doing a total hip or an open reduction and internal fixation. When we looked at their functional result with the Harris hip score, the patients that had the total hip arthroplasty did better than the patients with the open reduction and internal fixation, almost returning to the function of their uninjured leg. Again, though, this wasn't statistically significant, although close. When we looked at the SF36 outcome measure, we did see a statistically important difference between those patients that had the total hip and those patients that had open reduction and internal fixation, and we found statistically significant improvement in function and a statistically less pain in the patients that had the total hip arthroplasty. One thing that's very nice when you do the total hip arthroplasty in certain cases that I'll talk about coming up, we can make those patients weight bearing as tolerated right away. Of course, with all the fixation, all the patients that we fix, we have to limit their weight bearing. With the total hip arthroplasty, in 48% of the patients, we were allowed full weight bearing right away. In another 16%, we allowed partial weight bearing. And in only 35% did we have to restrict their weight bearing. So there's a few things that I have learned in doing these cases, and I'd like to share those things with you now. So the key point when you're fixing these fractures to put in a total hip is, as long as you can have 2 opposing arcs of bone anywhere on the acetabulum, you can get a very stable cup. And the cup must be stable. It's standard total joint surgery. You can't put in a cup that is loose and expect that it will become tight. The cup must be stable when you leave the operating room, and when you have 2 opposing arcs of bone, you can achieve that stability. So, if you have a posterior wall fracture, like this one, and you're missing that bit of posterior wall, I've found you can do a primary uncemented acetabulum you can cut out that piece of bone, throw it away, put in a primary acetabulum, uncemented acetabulum, very good stability, no problem, patient is immediate weight bearing. Now, if you've lost more of the posterior wall, you sometimes have to do an augmentation, although it's very rare to lose this part of the posterior wall down here. So as long as I have this part of the posterior wall and this part of the anterior column, I have 2 opposing arcs and I can put in a cup. If I don't, I can take a piece of that bone, move it down to there, put on a plate, and now I've recreated my arcs, a posterior arc and an anterior arc, and I can put in an uncemented cup that will ingrow from the initial stability. Now with the posterior column acetabular fracture or the transverse acetabular fracture, I can take care of these very easily. I don't need the anatomic reduction of the acetabulum. I need a good reduction, but I only need to plate the posterior column, and I can put in a standard uncemented cup, very stable, because I have 2 opposing arcs. With an anterior column or an anterior wall, here I have opposing arcs, so I can put in a good cup. Here, I do not have an opposing arc, so I have to fix this bone to be able to put in a cup. The same thing here. I can plate the posterior column, but I don't have an opposing arc, so I have to fix the anterior column. So here's an example. This patient had this anterior column fracture that I was able to then fix the anterior column. This is a high anterior column. Once I fixed that high anterior column, this portion here, I fixed this high anterior column. Now I have two opposing arcs, and I could put in a good cup. This is this case. Now, I didn't learn my own lesson, and I said, I have this anterior column fracture. I think I can fix this anterior column fracture, and I'll have stability, my two opposing arcs. So this is my case. I fixed the anterior column just with those screws. I said, that'll be good. That'll hold my two opposing arcs. And of course, at 3 weeks, if you don't have two stable opposing arcs, you will lose your fixation. Now, I've always, because I like to fix the acetabulum, and I always like to put in, I like to make the cup stable, and I put in an uncemented cup because I fix the acetabulum. I always lean towards doing that. Now, there's some reports, recent reports, of good results using a cage. If you don't have that anterior column, if you don't have the opposing arcs, then you either have to fix that anterior column to provide the anterior stability, or you can decide not to fix the anterior column and use a cage with reasonable results in other people's hands. I haven't used this technique. I can't speak to it much, but certainly in this paper from these authors, they had very good results using the cage. They had 30 cases, 4 reoperations, which is about similar to what I had in my series, and they had very good functional status. Most of these patients returning to their pre-operative functional status. So in summary, I do think for sure that in this group of patients, it's a very active group of patients that has an acetabular fracture, that has poor prognosis, that doing a primary total hip is a very good thing. I think this is particularly true for the posterior wall fracture in the elderly patient. Now, in my practice, a patient who is over 65 or physiologically 70, depending on the quality of the bone and the type of the fracture, there's no question in my mind that a total hip arthroplasty is a better procedure than fixing the acetabulum. As the fractures get more complex, especially with the anterior fractures, there's a little more question, but certainly with the posterior wall fractures, I think you can avoid prolonged surgery. The surgery is better. It avoids the secondary surgery, and they can weight bear immediately. So I think in a certain group of patients, the real answer in these older patients is a total hip arthroplasty. So thank you again from my new home, and everybody can come visit us in Hollywood.